Hypokalemia. Normal level of potassium ion is 3.5 to 5 millimole per liter. When potassium ion level go below 3.5 millimole per liter, it is called hypokalemia. Now, causes of hypokalemia. Causes of hypokalemia: loss from the body, redistribution into cell, loss from the body, redistribution into cells, and reduced intake. Loss from the body, it occurs through GIT loss, through diarrhea, vomiting, nasogastric aspiration, NG aspiration, intestinal fistula, renal loss, GIT loss, then renal loss. The renal loss include diuretic therapy, Conn's syndrome, Cushing syndrome, renal tubular acidosis, redistribution into cell, alkalosis, alkalosis, insulin therapy, beta adrenergic agonist, catecholamines, hypokalemic periodic paralysis, reduced dietary intake, potassium free IV fluid, reduced dietary intake and potassium free IV fluid. How would you manage hypokalemia? Management includes clinical features, investigations and treatment. Clinical features of hypokalemia: muscular weakness, number 2, tiredness, fatigue, myalgia, then abdominal distension due to paralytic ileus, then features of arrhythmia. Includes palpitation, irregular pulse, and hypotension. Clinical features of hypokalemia: muscular weakness, tiredness, fatigue, myalgia, abdominal distension due to paralytic ileus, features of arrhythmias such as palpitation, irregular pulse, and hypotension. Investigations of hypokalemia: measurement of plasma electrolytes, number 2, plasma bicarbonate, urine potassium, and sometimes calcium and magnesium. Urine chloride concentration if associated with metabolic alkalosis. A low urine chloride less than 30 millimole per liter is characteristic of vomiting, spontaneous or self-induced. Chloride above 40 millimole per liter suggests diabetic therapy. diuretic therapy. Acute phase or a tubular disease such as Barrett's or Gitelman syndrome. Differentiation between these latter possibilities can be assisted by performing a screen of urine for diuretic drugs. Finally, ECG. So investigations number 4: urine chloride concentration if associated with metabolic alkalosis. Hypokalemia is usually associated with alkalosis. A low chloride less than 30 ml per liter is characteristic of vomiting, spontaneous or self-induced vomiting. Chloride above 40 millimole per liter suggests diuretic therapy. Acute phase or a tubular disorder such as Barrett's or Gitelman syndrome suggests diuretic therapy. Diuretic therapy or a tubular disorder such as Barrett's or Gitelman syndrome. Now treatment. Finally, treatment. Correction of hypokalemia and treatment of the underlying condition. Correction of hypokalemia. Correction includes mild hypokalemia, moderate hypokalemia, and severe. Mild hypokalemia means 3.5 to 3 millimole per liter up to 3. Potassium containing diet such as fruits and fruit juice. Moderate hypokalemia 3 to 2.5 millimole per liter. Oral potassium ion supplementation. Example: potassium chloride tablet or syrup. Severe hypokalemia less than 2.5 millimole per liter. Intravenous potassium diluted in normal saline, not more than 10 millimole per hour. Not more than 10 millimole. One ampoule contains 20 millimole potassium. 1 liter of normal saline should not be mixed with more than 40 millimole or 2 ampoules. 1 liter plus 2 ampoule potassium. Treatment of underlying conditions. Treatment of underlying conditions. So the treatment option: correction of hypokalemia and treatment of the underlying conditions. Correction includes mild hypokalemia, moderate hypokalemia, and severe hypokalemia. Mild hypokalemia up to 3 millimole per liter. Potassium containing diets such as fruits and fruit juice. Moderate hypokalemia 3 to 2.5 millimole per liter. Oral potassium ion supplementation. Example: potassium chloride tablet or syrup. Severe hypokalemia when potassium ion level goes to 2.5 millimole, less than 2.5 millimole per liter. Intravenous potassium diluted in normal saline, not more than 10 millimole per hour. 1 ampoule contains 20 millimole of potassium. 1 liter of normal saline should not be mixed with 40 millimole. 2 ampoules. Treatment of underlying conditions. Now complications of hypokalemia. Complications of hypokalemia: cardiac arrhythmias, cardiac arrest, Paralytic ileus, metabolic alkalosis, muscular weakness, depression and myopathy. Muscular weakness, depression and myopathy, acute confusional state or delirium, constipation. Nephrogenic diabetic insipidus, nephrogenic diabetes insipidus. Complications of hypokalemia: cardiac arrhythmia, cardiac arrest, cardiac arrhythmia, cardiac arrest, paralytic ileus, metabolic alkalosis, muscular weakness, depression and myopathy, acute confusional state or delirium, constipation and nephrogenic diabetic insipidus. The ECG changes in hypokalemia: flattened T wave, ST depression and appearance of U wave. Flattened T wave. ECG changes in hypokalemia: flattened T wave, ST depression, ST depression, flattened T wave, ST depression and appearance of U wave. These are the ECG findings of hypokalemia.